So there's so much in mental health and in medicine in general, and in the diseases that we treat that is black and white, right? Either or black and white thinking is one of the cognitive hallmarks of rigid, um, unhealthy, addictive thought patterns. And I would say that the same applies to our categorizing as one or the other in the way of treatment models. So abstinence-based models historically has referred to treatments for addiction that do not include any sort of medication or any sort of substance. You know, the sole focus is on abstaining from substance use and medication use. I think the term abstinence-based model is confusing because it means different things to different people. And one of the things that we know in medicine today is that when people suffer from addiction, a co-occurring depressive disorder, post-traumatic stress disorder, and an eating disorder, there are oftentimes medications that can target one or more of those co-occurring illnesses. And we want to use medications that can actually help the person with their disorders in a way that doesn't make another disorder worse, right? So naltrexone or Revia is a medication that has been shown to be beneficial to people with addiction involving alcohol. That's not a medication that's going to make their addiction worse. Buprenorphine is a medication, or Suboxone is a medication that has been shown to improve outcomes for patients with addiction involving opioids. And medications too need to be tailored to the individual. So it's not a either or kind of proposition. When I have a patient in front of me, I want to do what's best for that individual patient. That being said, I believe all treatment is harm reduction. You know, even a person with alcoholism who does not want to use any medications and is on board with sobriety and abstaining from alcohol use is in a harm reduction process. So most people with alcoholism maybe also smoke cigarettes. Some of them at the outset of treatment are ready and able to get help with smoking cessation. Many of them are not. Many of them, it takes time in recovery for them to be willing to address other issues, whether that's a nicotine dependency, whether that's addiction involving sex and love, whether that's their depression, their eating disorder. So I think in essence, all of treatment is harm reduction and needs to be tailored to the patient. And treatment centers like ours can put boundaries around their therapeutic communities. So one of the boundaries that we have around our therapeutic community, whether you have an addiction or not, is we provide for patients and for our community a drug-free and alcohol-free therapeutic space. One of the primary reasons we do that is because as a treatment center that focuses on specifically treating patients with complex co-occurring disorders, patients many times want to work on trauma when they're with us. Even if you don't have an addiction, if you have depression and you're using marijuana every day, that's going to impact your brain and it's going to impact our capacity to treat your depression. So one of the ways that we can sort of get a baseline read on what's depression and what's not, what medications will work for you and what won't, is to take out as many of the other pharmacologic variables as we can. And for many people, that includes not using alcohol, not using marijuana, not using illicit drugs, that can cloud that picture for us, because it can hamper our capacity to, one, see what's really going on, and two, devise treatments that are going to be best for you as a patient in the long run.